I'd like to introduce you to our speaker today. Her name is Paige Hatcher. She's a physician at the university. She trained in Kansas and spent time at Kansas University and the Wichita campus. So the only question of real value, Shockers or Jayhawks?
Shockers.
Yeah. How did your bracket look at the end of that whole thing? Did you do okay?
Better than this.
Yeah, I'm imagining so. The Ducks got me in trouble. So Paige is going to talk to us today about complex care coordinators, development of a new role. She has indicated that she has no relationships to disclose. I'm sorry. Oh wait, no, that's professional relationships. You wouldn't want to share that with us anyway. Relating to the subject matter of the presentation, please welcome Dr. Hatcher.
So I recognize a lot of faces from yesterday, which is great. I guess that means I did something right if you came back. And so this time we're going to talk about care coordination, in particular the development of this role on the team. I know that you've had a talk. If you went to the Ron Stocks talk, then you had a little bit of team-based care, and I know Eva did some care planning conversations too. And so some of this may overlap, and if it's, so I apologize if it's total overlap. But to prevent that too, I want to see if we can pull out any burning questions that people walk in with today. Is there anything in particular you guys want me to cover this morning? Okay, the one thing I had one question ahead of time.
I think those of us that have not really incorporated actual care coordinators, understanding what the qualifications of those individuals need to be, ideally what their scope should be, how we get this set up and started is on my mind anyway.
Absolutely. Okay, I can make sure. I've got,
the return on investment.
Yep, I've got that one. That's the question mark, right? So I don't have very many slides for this talk because I really want this to be pretty interactive. And so if you have questions, feel free to interrupt me. I can totally handle that. Can everybody hear me if I'm away from the mic? Yes? Yeah. Great. That'll make it easier on me. So you guys have seen these statistics before, but this is why we're talking about care coordination, because this is from I've got the references at the end of my presentation, but these are some national estimates, and people are starting to feel really overwhelmed, and that this is an impossible charge, and that there is just too much to do, too much to cram into their day. So the second bullet is the one that's really interesting, is if your panel size is this, which is a large panel, I know people's panels may not be quite this big, but that would be 7.4 hours a day to provide all the recommended preventive care from the USPSTF, and 10.6 hours a day to manage their chronic conditions. So that's a 17-hour day before you start seeing patients. Obviously that's a problem, and that's 18-hour day, yeah. So that's why you can't do it by yourself, and why we're talking about teams.
And that doesn't count what you do after hours. So.
Yeah, it doesn't count after hours, it doesn't count billing, it doesn't count for writing in the medical
Getting
record.
the EOR finished.
Right, yeah.
So that says, pardon me for not understanding panel size, increase to 2,300. Increase from what? What is it now? What is
this is a
reasonable?
period of time. So this study has to do with the baby boomers, and so this is in the next 10 to 15 years, as the average age of our population increases, our panel sizes would have to increase to 2,300 on average in order to accommodate all the baby boomers.
So what's an average panel size now?
That is a hard question to answer. The reason why is because it depends a lot on the acuity of your patients. It depends a lot on what type of provider you are.
And maybe a ballpark? Is it 1,500? Is it 2,000?
It's probably about 2,000. It's probably about 2,000. But for a university, so a teaching clinic, they're going to see a lot fewer patients. And not everybody's full-time. The full-time provider is more rare than it used to be, and so it's kind of hard to guess. But
thank you.
Yeah, no problem. So I'm quoting heavily today from a work of Thomas Bodenheimer from UCSF and California Healthcare Foundation. he has adapted this model called Share the Care, which is initially it was actually created to care for caregivers of ill patients. Because we identified, as you all know, that if you have a terminally ill or very chronically ill or severely ill individual, the caregiver who's often spouse or child or paid caregiver can take on a really significant burden and needs a whole network of support. And so that's where this model came from, and it was adopted to the physician of those patients as well. So the idea is to shift from the lone doctor model. As I'm sure you all know, the system that doctors are trained in is that the doctor has the responsibility to make all the decisions and then delegates the tasks out to everyone else. The captain of the ship model is how it's often talked about. The problem with that is that just this model of delegating tasks from the doctor to the team implies less work for the doctor, which is part of the goal, honestly, given the numbers that I showed on the last slide. But the problem is it's met with a lot of resistance because it is perceived by your staff as more work for them. And so that is not a very pleasant way for them to feel about this change, and that's part of why this model is being met with quite a bit of resistance. And so the we paradigm, so the real team, right, is that it's about relocating responsibility, and the panel is cared for the team, and the doctor really isn't the captain, cannot be the captain of the ship anymore if this model is successful. Like the doctor or the NPA has to be one team member working together with a group of others. So I've just put up some framework here to remind me kind of to talk about, but these are the things that have been demonstrated in practices where team care is effective, people are happy, both providers and patients. These are the common elements. The first is co-location. This is a huge problem because our offices were not designed this way. Okay, doctors' offices are over here, there's a nurse's desk, front desk is somewhere else, and so it's literally about physical space. So if you've ever toured a clinic or worked in a clinic or seen a clinic like this, with co-location it means that the team caring for a certain panel all sit together. And so, for example, when you go to chart and work on your computer or write your notes, you're seated right next to your nurse and your support staff, like the secretarial staff, sits in there with you. Potentially the person taking phone calls sits in that room, which is a very different model. The reason for that is it creates less duplicated work because everyone knows what everyone's doing. I can't tell you how many times I've heard my nurse sort of start, and you guys I'm sure have heard this too, but you'll imagine that it happens a lot more frequently if you're sitting right next to them and overhearing their conversation. I'll hear my nurse on the phone with this patient. I don't know who the patient is, potentially, unless some of the patients talk very loudly and I can't figure out exactly who it is. But I'll hear something come up and I'm like, oh, Julie doesn't know X. That's why this is happening. That's why Julie is wasting her time on the phone right now, because it wasn't clear in my documentation, or I didn't tell her, or I just have some knowledge that she didn't know. And I tap her on the shoulder and I said, Julie, she puts them on hold, and I say, this happened last week, this is what you need to know, and then the problem's solved. And so the problem when we're not co-located is that never happens. The downside, yeah, go ahead.
Well, this co-location thing is good and interesting, but a lot of times you need to have a conversation with somebody without a huge amount of noise around you, chaos.
Yep, that was my next.
Okay.
Yeah. So I had a head injury in 2011, and I am immensely sensitive to distraction. And so that is the problem, is that it's like a really noisy environment. And so that's the trade-off, and so you have to think about, it's really about planning your workspace. And so for me, it meant that at the end of the day, when I'm finishing things up, I need to go somewhere else to a quiet space to chart, and there has to be a quiet space for that to be. And I'm not going to chart, I only have like half an hour left, but in order for it to be half an hour and not 3 hours, I need to be in a quiet space to do that. And so, it's about assessing the needs of everyone and finding the best space and actually planning for that space. And that's not how our clinics were designed. The problem is it's really hard to then, it's a physical building, right? I mean, how do you fix this problem? So people are getting really creative, doing things like sending all of their billing and people to work from home so they can use their space in the office. So figuring out if there's a way to open up space that they can use for other things for people that don't need to have those face-to-face conversations. Yeah.
So I see pictures of and here talk about the team all sitting in the same space. But when I'm seeing patients in the office, and the only time I sit is when I'm sitting on the stool in the exam room, right?
Right.
There's not a time when I'm just like hanging out at my desk or out at the, you know, people talk about the doctor's office is back here, but yeah, I come in and I put my coat on my chair in my office, and then I go back to my office at the end of the day, you know, to get my stuff or maybe eat my lunch. There isn't, I'm having a hard time, and maybe it's because we're on paper charts still, not on electronic medical record. Maybe there will be these times when I'm sitting and typing, but there's no time when I sit during the day.
There definitely is more chair time once you go to medical records. That was the one thing that I realized I just hated because I didn't go to medical school with electronic medical records. So when I came to residency and switched, that was definitely a change. There is more chair time. But so it's not just about the seated space, but it's about the working space too. And so what a lot of people do is actually do some sort of workflow diagram where they actually like follow around the patients or follow around the doctor or what other staff and realize where they go. And so the solution that my clinic has come up with is the MAs are actually all seated at desks in the hallway. And so I'm walking past them so they're seated right here and the doors to my clinic open right here. And so I'm literally walking past them 100 times a day. And so those conversations, so we still are in the same space as much as possible, even except for the seconds when I'm in the room. Yeah.
Just to respond to Gary's comment, I've been doing this for 2.5 years, co-located. We have 6 people each have 4 foot on a 24-foot wall. And there's 6, so we each have our 4 foot. My MA sits here, and the med student sits here. A couple of thoughts. One is, we always start there a half hour before we have any patient scheduled. And that half hour is always reviewing the day and deciding what we're going to do as a team. And so there's a lot of time there at the beginning of the day, at the noon time, and at the end of the day when we're answering phone calls and stuff where the MA's answering phone calls and I'm overhearing what she says.
Yeah, and I'm going to talk about huddles too.
The other thing that I've learned is this: quiet. So, because everybody, the noise starts to go up and everybody's talking and it gets louder and louder. That's the sign that we have for, you know, we can't hear each other think.
I also wanted to just mention 2 things. I mean, one is, again, your work day about what you're doing. You know, if you think about your physical space and you still have a place where you can make a quiet phone call, that doesn't happen that often. You're not making phone calls that often to where it needs to be quiet as a physician. But to have that space is important. But also, again, thinking about your physical space. In my clinic, when we did this, we actually basically took everybody out of the nurses' stations. We have 2 complete areas of nurses' stations that we don't even use anymore. So we're actually putting exam rooms in that area, so we're actually able to increase our capacity to see patients because we're using our physical space differently. We haven't built a new clinic or anything like that, and we don't have everybody exactly in the same room, but they're essentially in line of sight of each other and in hearing distance of each other. And yeah, I just would agree that it's not just communication, but actually that teamness or feeling of connectedness that changes.
Yeah, so if you can't physically be co-located, the idea is to talk about it and acknowledge that this would be ideal, we can't do it, so what other system are we going to do? And so there's a lot of, you know, if you wear pagers, some people have radios, so some people are using dots or flags and sort of standardizing these things so you can figure out where the other person is all the time. Because that's part of it too. When you're on your feet the entire time and not ever in one place, it can be hard to track you down, and it can be also really frustrating as if you walk out of the exam room and can't find anybody. And so there's these systems of like, where's everybody supposed to be, but just talking about. So I guess the main point is that, and that's pretty much the whole point of the entire model, is to acknowledge what the needs are, to talk about a system and address them, whatever works for you. In this case, like I said, I had to have special accommodation for the noise factor, and I wear my headphones, and everyone knows that it's like a alpha wave or like concentration wave that like blocks out the whole rest of the sound, and then they just know that they can tap me on the shoulder because I might not hear them, and so we just have to talk about that stuff. some of these things we may go back to. Some of it, so mapping team workflow we talked about, so that's literally walking through, you end up with these big charts of where everyone is. The mapping team workflow is really helpful. It's sort of stolen from Lean. I'm not a Lean expert, I'm a rapid cycle improvement person, so Lean isn't my strong suit. But the benefit of Lean is that you end up with this map of processes and you know exactly how many steps you have in the process. And there is so much waste to be uncovered and so much duplication and so much this is what the right hand is doing and the left hand doesn't know it. These maps can be really complicated and really impressive. Yeah.
I need some remedial acronym.
Oh, sorry. Lean is the Toyota system of, it's from engineering. The words are all in Japanese, and so it's not really actually, most of them are acronyms, it's just not English, but it's the idea of taking a manufacturing process and applying that to healthcare and understanding where the waste in your system is and trying to undo.
So it's a workflow idea.
Yeah, exactly, yeah. So team goals we're going to talk quite a bit about, so I'm going to leave that one for later. Team treating, meeting, and expectations, we're going to talk a little bit more about that. But everybody has meetings. We're all in meetings all the time, it seems like. And part of what this model says is the most effective meetings are the meetings that are limited to the people that you actually work with. So an all-staff meeting, an all-clinic meeting, may not actually be helpful because you can't do any work there. That is a process where the administration or whoever's talking is taking information at you. You're not actually having, it's not really a team meeting. It's a announcement period or an informational session, right? So that isn't enough now. And the meetings can be short, and we're going to talk a little bit. Some people are doing them every day. We're going to talk more about that. Team training. So the coordinator role, it's one of the things we're going to talk about today in particular. Nobody is trained for that right now, straight out of their professional school, okay? Going to nursing school does not train you to be a team coordinator. Going to medical school does not train you to do this. It is not, you may have had a lecture, you may have had an elective, you may have had a course, but our current professional training does not prepare us for this. So the key is you either have to go to some sort of session and do CME. You have to, there's webinars. Honestly, reading Bodenheimer's stuff, his stuff is really accessible because it was funded by the Healthcare Foundation of California, and so there's some really good sort of self-tutorial materials, and that's all you can do. You don't think you have to spend a lot of money. But there are some basic concepts that are very, very different from the hierarchical way that we were all trained. And so it's critical that everybody on the team gets some sort of training. Otherwise, no one will know what they're supposed to do. Although it's intuitive, some people can just naturally do it. I've walked into clinics and found someone going, wow, you are doing it. You don't know that you're doing it, and your title is not that, and no one, like, your teammate not have recognized it, but this is what we're talking about right here. So some people just naturally do it, but just like some people naturally do a lot of things, but I think it's really critical to get some sort of education about this. Standing orders we talked about, this is the backbone of chronic disease and immunization and all of it, and a lot of people have been using standard orders for a long time, but this is really how things get protocolized and systematized and automated, so that it isn't up to the doctor or the middle writer to remember every time to order something, it just happens. So key elements of team building. I think actually I'm going to come back to this slide potentially, but I mean this is sort of, you guys can look at this. This is an article, so I've peppered some of this with articles that are just really foundational if you want to do some reading and are planning on going to a course about this. And this is a really good one about teams. It just defines like what is a team, because I think that's the tough part, is that the teams look so different in every clinic, so different, that it's been really hard to say this is a team, this is what a team should be, because there is no such thing. Your team should look like whatever the needs of your personnel and your clinic and your patients should be, and so it's really impossible to define a team. And so some of this is just sort of definitional. That said, team size and composition, the optimal size has been found to be 6 to 12 members, okay? Again, to do care coordination work, there has to be protected time for all team members. It doesn't have to be a lot of time, but this cannot be an add-on or it will fail. The system designed that way it's just not possible. And that's what most of us feel. We just feel like we're running on this treadmill, or feel like we're being told to do this add-on stuff, and then we're failing and we're sort of miserable for it. And the reason why is because it's just not possible. Yeah.
In our clinic, we have RN care coordinators, and I've found that the opposite in our cases is true in a way, in that care task gets added on to them that is not necessarily care coordination. It's kind of, because it's a new role and hasn't been well defined in the past, it starts to become a catch-all, like, okay, let's add that on to the duties of the RN care coordinator.
Right, and so that's part of when you're talking about, I figured we'd go back to this slide. So yeah, is about actually setting up job descriptions, assigning the division of labor, and so it does take some sort of retreat time, I think is the way a lot of people have done it, to like make a list of, this is all the stuff that we do, and then I've seen people like have a list of, this is everything that ever happens in this clinic, and then have sticky notes on the wall, and you go and you put, okay, this task goes here, this task goes here, this task goes here. That feels a lot different than this is my job and what task can I give to somebody else. Then everybody as a group saying, these are the tasks that of everything that ever happens, everything from filling out an FMLA form to a refill prescription to an office visit, and then putting it on the wall. Yeah.
So the 6 to 12 member team, is, so most of us have over the years been in offices where there are primary care doctors with an assistant, and maybe they have a second person. But are we talking about taking that team of 2 and making them into a team of 12?
Yeah, so we define that pairing as a team lit. So there's a whole nother, if you are in a smaller practice and you don't have a disparate number of people, there's a whole separate field of literature about team lits now, because they have recognized that, yeah, it doesn't make sense to call your whole practice a team. If you're a provider group of 4, provider group of 2. So yes, so the answer to your question is no. We're not saying that you should smash all your teams together, but that we'll talk about teamlets, and I'm going to talk about that at the end.
Yeah, I just want to comment, I think stability of leadership is really important, and it's really super hard in a residency program.
Yeah, residency programs have their own fun, which I can talk a lot about because I've done that. I feel like, again, it's all about protected time. If your residents need protected time too, and if they don't have protected time for this, they're going to fail just like everybody else. And that's a department commitment. That's that's a financial decision for a lot of people, but as the teacher of the residency QI curriculum, obviously, at OHSU, I fight and fight and fight for that protected time, but I also see it pay off. I love watching the light bulb go on for residents. That is really, really fun. And we have done, and I could tell you stories about resident practice in particular. For example, opiate prescribing. Our residents were doing it better first because we had a QI project. And then the faculty got jealous because the residents weren't miserable with their chronic pain patients anymore, and they started using our stuff, and they wanted us to teach them how to do it. So it doesn't, honestly, student and resident learners are not stuck in the model of this is the way we've always done it, and can come up with the most innovative and creative ideas, and so it's even more important that they should be on the team. I still struggle with that. Yeah.
So you're talking about protected time. Protected time to do what?
Protected time is to do, so
For the team meetings?
So yeah, so it's for the team meetings, it's for a PCP, it's gonna, or the decision maker, it's gonna be approving protocols, it's gonna be reviewing lists of patients to make sure that the ones that are included in the program are important. It's to be addressed for providers, to be addressing the one-off, the patient that kicks out of the process because they didn't fit the protocol, and then you have to deal with that patient on a one-on-one basis. It's making phone calls, it's charting, it's all of the stuff that doesn't fit in the office visit.
All those patients in the care plan.
In your practice, you define that as Saturdays.
Right.
or every minute you're not in the room alone with the patient.
Right.
Right. So I'm going to talk about it on my return investment slide. I promise.
Everything we do that's not supported by our current payment model.
Right. Yeah. So I have some data. Yes.
The one thing I will say, I mean, I'm one of the owners of a private practice group. We eat what we kill, all that stuff. We're in sort of an emergent phase of doing some of this, and one thing I feel like it has let us do is front load work in a more organized way that we were having to play catch up with afterwards. So because we try to get all our diabetics in October, we don't get refill requests, their A1Cs are taken care of. So actually for us, getting more organized and doing the work ahead of time has helped, but there was an upfront investment to make it happen.
So for example, I can give you another example for that. So I'm at Richmond Clinic, which I did my residency, and that's where I moonlight, and we have a horrible phone call problem. We did. Our abandonment rate was so high, if you guys keep track of that. Our people were on the phone forever. They could not get through because of the volume of calls that we were having. Then we did a different project about refills, and we fixed the refill problem, and the phone call volume just dropped like a rock. And we didn't have to do anything to fix our phone calls. I mean, we did, but it wasn't a phone call problem at all. It was not a staff problem. It was a process problem about refill requests. And so fixing that team structure actually totally fixed another problem. We were just really barking up the wrong tree on phone calls and didn't realize, and so, but it had to do with just there was a bottleneck in our system, and that bottleneck was there, and the bottleneck still exists, but now we've alleviated the volume, and so the bottleneck isn't as much of a problem. And so that's why the workflow processes are really important, because you can figure out where your bottlenecks are, and then try to make sure those tasks are distributed evenly and cross-trained so someone else can cover if someone's gone and that sort of thing. So the stability of membership part, this is part of where the financial return on investment comes, because turnover is one of the biggest costs that you can have in your organization. And if you're a small organization in rural somewhere, I mean, your membership may be more stable just because you don't have that big of a workforce. But it's really expensive to hire and retrain someone and deal with all of that. And so, in my opinion, that's where most of the finances are coming from, not necessarily the way that we think about from billing, because people are really happier working in teams and they're not leaving. Turnover in team-based organizations is half the national average in other healthcare organizations. So, I mean, it's really, really making a huge difference on satisfaction.
What did you solve your refill problem?
That was a very long project. I'm happy to talk to you about that. But it basically meant that it was a huge process that was a really dedicated patient education effort, honestly. It was teaching the patients how and when and what and where to request refills. And also showing the providers that if I refill within 24 to 48 hours, my patients call 1 time. If I refill in a week, my patients call 8 times. And just the volume, it just exponentially kind of expands. So we can talk about that. It was a lot of fun. That was a lean project. So just, you know, feel like lean. So the last thing I've talked a little bit about change management. I'm going to talk a little bit more about it. But this is a process. Okay, so this is a process that leaves doctors feeling really uncomfortable because they have to let go of a lot of control. Okay, you set up your protocol, you say this is the decision that we're going to make, this is how we're going to handle this, and this is how it's going to be applied. You pilot that and you test it and you make sure that it works, and then you have to let go. And that is really, really hard for doctors to do, and so that's something that really has to be managed. And so, I think especially in smaller practices where there aren't that many people on the team, and there is a very defined relationship where the provider makes the decision and the MA or the RN sort of carries out the task. And it really is recognizing that RNs are trained to make decisions, and they can make a lot of decisions within certain parameters, and we really need to let them make those decisions. And most of the things, part of it is because I spend my whole days, even now working in team management, I can go a whole day without ever needing my stethoscope. I still can. I can spend a whole day doing nothing but social work and empathy, and those are important things, and I like those things, and I'm good at them, but anybody can do that in my office, honestly. I work with a very caring group of people, and it doesn't have to be me doing that, and so there are some changes. There's changes in what makes our role satisfying. I mean, a big part of why my role is satisfying, you know, part of the reason I went into medicine is because I wanted to take care of people. I wanted to hold their hand when they were sick, and but now it's about the warm handoff. It's about transitioning that patient to somebody else and letting someone else do that. And so it's recognizing that these are some major cultural shifts, and some people are going to be unhappy, and it's just talking to them about why. I have some more specific examples about that later, but it's a big deal. Yeah.
I don't think creating
protocols and standing orders necessary is giving up control. I think it's different control. You have a lot of control. It's up front. You have all the control, and then it's not, and you still have that control. It's just someone is carrying on those orders on your behalf.
Mm-hmm.
So I never thought it was giving up control, and I kind of learned the hard way. My MA has bad ADD, and so if I never wrote it down, it never got carried out. And the more I wrote down, the more she carried out. And so it was more of I had standing orders by default, because if I told her nothing happened. If I wrote it down, it happened all the time. And so I wrote it down once, because I don't like to write anything down. If I wrote it down once, it happened all the time. And so my standing order just came out because my MA has ADD.
And some people are fine about it, but just something to think about, because often, I mean, if you work in a small clinic, things are really personality dependent and skill dependent. And so it's really sort of recognizing why certain people may be really fighting you on this. That may be one of the reasons why.
Then everybody else is standing orders.
Yeah.
But I'm gonna add that, but yeah, they're standing orders, but it's like there's a feedback loop that
right.
if it deviates too much from the orders, the MAs, we have MAs, we don't have RNs, we have MAs who are excellent and who could definitely be docs. I mean, they really are great, and that's just luck of the draw. But when it gets to the point where you kind of, it's like a negative feedback, it has to come back to us. So there is always control there, because when it exceeds their decision-making capacity, it's built in that it does have to come back. So it works really well.
Just a comment on the refill and the re-engineering. One of the things that struck me is that we historically have used refill as a trigger to get the patient to contact us and to decide if we need to see him for hypertension or diabetes or whatever. And that has created a tremendous issue for us. And part of the re-engineering has been refill for a year, and then make sure that your A1Cs and your blood pressure checks and stuff are automatically scheduled in a way that doesn't require the refill to trigger that.
Right.
And
it's a really indirect way of doing it.
It is, but it really reduces the number of refill requests that come across our desk that require us then to pull the chart up and look, when was the last time we had such and such.
And I think I have something specific about that particular issue. Yeah, right there, your plans. So low-hanging fruit. So just like in my other talk, I kind of gave some examples of places where I think are easy ways to start and learn this process. I've given some more examples in this talk. So this is an article from Family Practice Management, which they said yesterday is, in my opinion, the gold mine for this, because it's written to family doctors, so we understand what they're trying to get across. But the methods and the procedures behind them are very sound organizational culture and strategic management type concepts. And so this article gives a really good example about how to fix the refills from that particular. It doesn't talk about the whole engineering of how patients access you and request refills, but it gives some ideas for, it literally gives you a list of, these are all the medicines that if a patient calls to request this, you should just refill it for a year, you don't even have to ask me. You make a list of that for your staff. This is a list of medicines that if they call about this medicine, X needs to happen. If they call about this medicine, Y needs to happen. And it automates all of it so it doesn't come to you. You don't have to spend the time making that decision and answering the same question over and over and over again, but just writing it all down. So this is really nice because it actually, if you go to the website, it actually lets you download the Excel template that he used. You can just plug your medicines in it, and it's just really, really easy. This is, yeah.
Is that the medication list or a category list?
It's a medication list. It's specific to specific medicines. Because you want it to be...
So it's the whole PDR?
No, because...
What is it?
Yeah, so the list on this medicine, so it... So you can do it by category. It's not the whole PDR because there's a lot of medicines that if they get refilled... So we don't prescribe the whole PDR for our patients. We only prescribe the same medicines over and over again. And so this is a list of common medicines in your practice. This is the example of the list that he came up with. When you look at it, you're going to see that, well, I usually prescribe, ranitidine instead of omeprazole, and so, it's pretty clear. It's a prompt, so it will help you create your list for your practice. And it's not foolproof. You'll have some fall through the cracks, and then you'll say, we need to add this to the list. Yeah.
And of course that changes a little bit as people transition, or if anybody's changing to like Epic and Ocean, because
your refill request will come directly into your in-basket on computer from the pharmacy. So you'll still be able to scrub through the patient's chart as you're doing your own refills. And
so you can set up that so that refill request doesn't actually go to you, it goes to your provider. So that's what it does, is it doesn't go to you ever. That person looks at the list and then shoots the ones back to you that you have to do. And they put in verbal, or they put in through the protocol all the rest of them. Yeah.
So we're problem solving this right now in our practice, and we're struggling a little bit with the scope of practice of MAs to be able to make medical decisions. And the issue around refills has come up around categories of meds. How do you know that they're on lisinopril for hypertension versus diabetes nephropathy? And so what's the category? Who's making that decision? Does the MA understand what a diabetic med is? Do they know what the diabetic med list is? When it goes from generic, when it goes from brand name to generic, do they know that the generic is the same thing as the brand name? Do they recognize the name because they don't read medical literature? We're sort of struggling with that whole issue of what's their level of expertise if they're going to do all your refills.
And that's why when you look at this list, lisinopril is not on it. So this gives you a nice starting place, I think, to teach. So I think what's hard about all of this is it's really overwhelming, and you have to teach people how to do it before you can do it. Because like I said, none of us are trained to do this. And so I like starting with a smaller list of things that are really obvious, like loratadine, something that I'm going to refill every time it's over the counter. Like there's no reason why I'm never going to refill that, to teach people how to do the process. And then you can get more complicated. Then the MAs are going to come to you and start saying, hey, I've seen X or I've seen Y and I want to do this. And you can start figuring it out. And you'll also, through piloting something that's easier, figure out what the skill level is of your individual staff, because like I said, especially in a small practice, you're really personality and person and ability dependent. And so your process could look a lot different. I mean, I know some practices that have medical assistants and they never occurred to them that they would have an RN in this role because their medical assistants are performing at such a high level. Why would they pay for an RN? And so, I mean, I've seen both ends at OHSU where all the care coordinators are RNs by statute and you're like not allowed to ever put an ME in that role. So it's really, so this, the reason I like this article is because it gives a template that anyone can start with and then you can adapt it to your own personal situation. Okay, so huddles. So this is sort of related to huddles, but this is the pre-visit scrub for preventative care. So this means that a staff member goes through your schedule the day before or the week before, depending on it kind of depends on how your patients usually schedule, and makes a list of all the preventive needs that they can anticipate for your patient and pre-orders those, flags them in the chart, whatever it is, puts a sticky on your paper chart so that you don't have to remember tomorrow when you see the patient. This doesn't have to be perfect. People have spent a lot of time and energy doing this because they want to make sure they capture everything, and that isn't always the point. The point is to capture the easy things every time with a minimal amount of time. What I put in here is the way that my clinic does it. We agreed as a group on the top things that we want everyone to have. This isn't comprehensive, it doesn't include every screening thing everyone could ever have, but these are the things that every time we want to know this. And so the day before, this is actually a team coordinator. This is not a person with any clinical training at all. This is less than an MA in level. And they go through and they say, and we've defined for them what it is. So they know where to look for this, they know where to look for this, where it is in our chart, they know exactly how to find it. And then they go through and bold, put red stars and whatever to tell us that when you see your patient tomorrow, you need to talk to them about X. Or sometimes it just comes back that it says, hey, because we're doing this, so a lot of these fields are blank right now when we first started, right? Because a lot of it was the providers hadn't been trained to fill it out. And so this is actually an old version of this template, but it says colon cancer screening, it says what they have, and then what is really important is it says next due. And that then is all the staff member has to look at. If their appointment date is within 3 months of the next due, they flag it. If not, they just move on. Because you're the one that interprets this. You know, that if you have your patient on whatever schedule, you're going to know that. And so, in the beginning, there's this like catch up as everyone learns how to do it. But eventually, it speeds things up tremendously. It can really bring your patients up to date.
So do you have that one person for each team?
We do, one person for each team. So that's the same person that then takes phone calls. So we have a big clinic, so we have lots of providers, but they're not just doing this. They're also the ones that's mailing. Like, I mean, it's our secretarial staff. That's what they're doing. So they're also talking to patients on the phone, they're also answering both outgoing and incoming. But they're also just doing a lot of stuff.
Where is this? Is this somewhere in your chart? It's sticking out to you.
This is in our chart. This comes out. It's in the problem list. Which is actually a huge problem because it's not a searchable field. So for my data talking to you yesterday, it's kind of causes lots of problems. But everybody does it a little bit differently. Honestly, though, I mean, paper. If you still have paper charts, I mean, part of the reason we're having trouble is because the system, the way we developed, would probably actually work better in paper charts, and it would be a lined page on the inside of the chart that has this, yeah.
So Paige, you talked about a team coordinator. So, just the way our office is set up, we've got the front office staff that sits up at the front where the waiting room is, and they're answering the phones and scheduling the appointments and things. And we've changed that to where now that what we would think of as a receptionist person is now co-located with the team?
We started with one team coordinator that was an admin staff type person, a secretary staff for the entire clinic. That was in addition to the phone staff. So this was in addition to the front desk. They're considered like front office. They go to all the front office meetings and they're trained with them because they have the same level of education and background. But we just pulled one phone call person off because we had several and made them, you're the one that's going to manage all the paperwork. It was so useful and saved so much time that it's just explode. Like we just keep hiring more because it has saved so much time and energy, and so we now have one per team. But we just started with one, and then that person kept track of their time for us and kept track of what they had undone at the end of the day, and we figured out how much FTE we could assign based on this log of what they did for us. And we expanded one at a time, so we had one, then we had two, and then we had four, and now we have 8, I think. But we have a really big clinic. Yeah.
Can you help me understand a team in your clinic?
Yeah. So my team is, so we actually don't, I wouldn't use my team as an example. That's why I haven't talked about it.
Optimal team in your clinic.
Because we're a resident clinic, and so our teams are screwy, and we have too many people in our team. But the Bodenheimer article that I referenced describes exactly how many you should have, and so it talks about there's ratios, and you need 2 MAs per provider and 1 team assistant or team coordinator for 4 providers, and it gives you some of those ratio numbers that are ideal. My clinic, honestly, our teams are way too big because we have 3, and part of the problem though is none of our providers are full-time. Right. Even the faculty staff are not full-time because they have research and teaching, so it's a little bit tricky.
I think some stuff I've seen in his literature talks about a team where the clinicians are a physician and a mid-level provider. And then you sort of build, very physician-centric, guilty as charged, but you start there and build a team around them. But there may be 2 MAs and 4 MAs for the 2 of them, and a nurse and a RN and a person on the phone. So you could usually have 6 support staff.
Absolutely. One piece would be for huge staff. But that depends on volume and size, and that allows you to take care of more patients. So that's the thing. It's about panel size. If you can't see more patients, if your volume can't increase, then you can't increase the size of your team because you can't support the staff. And so it just depends. That's part of the reason why at Richmond Clinic we've been able to establish the teams, because we doubled our catchment area this year. I mean, we're just swinging our doors wide open and say, everybody come see us. And so we're just whoppingly increasing our patient volume. But, so that's the limit, the goal is to see more patients per provider, and so if you don't need to do that, you may not need to increase your team size, you may just need to reallocate duties.
We added an extra MA per team to go home.
Yeah. And
so how many MAs per team? 2?
We have, typically there would be 2 clinicians working. They would each have an MA. In addition, there's a float MA who is working for either somewhere in the range of 2 to 4 clinicians who are in clinic that day. And then we have an additional person who's kind of an advice care coordinator hybrid, I don't know what.
Yeah, and when they're talking about stability of membership, one of the things they're actually talking about is not having a float person. So it's also turnover and in and out, but it's also literally as a team you will function better, because a lot of this is like I said, personality dependent. It's little quirks. It's because there's so much of gray art of medicine, And if you don't know that about each other, it's hard to work together. And so that's one of the big complaints in the resident clinic, is that the MAs, we always just get whatever MA is available, because we're not there as consistently, especially as first and second years. And then we never know how to work with our MA, because we never have the same person twice in 1 month. So
Which is ludicrous, right? I mean, they're of all the people who need this stuff.
yeah, I mean, yeah.
No,
so,
we have that problem too.
Yeah.
So, I'd like to challenge one word you used, which was
Yes.
see. We need to see more patients.
Oh, sure, of course.
Because that's one of the things that I find that people get afraid, the fear comes up. If I'm going to increase my panel size, it means I'm going to have to see more patients. And part of what we try to do is decide who we don't need to see.
No, it's true that the seeing them in person, so I would say yes and no. So seeing more patients will result in more revenue. So
You
seeing
have to see more
more,
patients if you're gonna hire an MA and less payment.
yeah. So
Change.
the absolute number of patients might increase. So that's more like new patient visits and more, but you might see each patient less frequently. And so there is sort of this calculus to it. You do sort of have to see them in the office if you're going to get paid right now.
Well, my clinic is under the new alternate payment methodology right now, so we are getting a PMPM for all of our Medicaid patients. Anyway, and so you do want to hire a bigger panel.
Yeah.
When you're under that, and so this is key to that construct. So if you are in primary care, you are headed towards this different payment. This is really of the essence.
So I'm gonna have to struggle. It's amazing I can't get through 15 slides in an hour, but I want to talk about a few more things, and then I think we can come back if that's okay, because I've still got some really good stuff. So this one I wanted to talk about in particular, Dr. Irving. This is what I call the power of the green dot. This is how you get people motivated, in my opinion. So this is visual and it's public. So this is the difference between giving everyone their data at a meeting and giving it to them in emails, and even sending, because some people, they give the providers your data, but they only give it to you by email, and you can see everyone else's data, but you kind of have to take time to look at it. This is posted in the break room, this is posted in your workroom, this is posted potentially where patients can see it even, depending on what visual measures you're using. And so what it is, so we decided, so this was the weekly scrubbing that I showed you. They go through the list the day before, and the team coordinators bold everything, and they say, there's usually one thing, PAPS or whatever, and then after your chart, they actually audited 2 charts of yours for the week, and if you, on both occasions, saw what the team coordinator did and responded, you got a green dot. If you only did it once or didn't do it at all, then you got a red dot. And then they post it up and everyone gets their dots, okay? And I have an urgent only clinic. And so I see, because I'm a moonlighter and because I don't work on my own panel anymore, and so I'm frequently asked, and we've asked all the providers to do the preventive care for everyone's patient. It doesn't matter who you are. If I'm seeing someone else's patient and it's bolded, PAPS urine, it's not that hard for me to schedule it, even if I can't do it during the urgent visit, and I should be attending to that. But I frequently wasn't, because my patients are coming in really sick and go to the hospital, and I was having trouble staying on time and learning how to do urgent clinic, so I was getting red dots every week. And that was fine when half of us were getting red dots every week. I don't really care so much. But when I was the only provider getting a red dot every week for my clinic, now I just have to do something about it. And so this is the adoption curve, right? This is the whole process. So there's early adopters, there's late adopters, and there's sort of majority, and there's actually 5 categories, and there's a lot of science behind this. But the late adopter will change when it seems like the standard of care has changed, when it seems like the majority of everyone else is doing something different than what you were doing. The late adopter will get on the bandwagon. That is the tipping point for most people. There are, beyond late adopters, people that just are never, it's just not gonna happen. But if you're going for that late adopter, and I believe there's hope, I don't feel like we have to just abandon everyone, it's when the majority of people change. So, because that's really the key to this care coordination, is if your staff is spending all this time doing all this work, and you set up these protocols, and your nurses are doing it, your MAs are doing it, your staff, and the doctor's just ignoring it, then that really undermines, and they're not ignoring it because they're malicious, they're ignoring it because they just forgot, or they don't have time, or they don't understand, or whatever it is. I mean, there's a lot of reasons why people may not do what the team agreed to, but if the provider doesn't have buy-in to the team process, it's not going to happen. And so you set these team goals, and these goals that you decide on are determined by the team, not by the provider. And people are judged, some of them, so we had one that was printing of the after-visit summary after the visit. I was also very bad at that one. And that was judged, we were judged in our pairs with our MAs. So our MAs, because they can print the after-visit summary just as easily as I can, and so the green-red dot rating actually went to the pair. And so so our MAs were really motivated to print all the ABSs for the doctor they were working with that week, so that their rating went up too. And so, but it's really critical that it's not the doctor that picks the visual measure, especially if the doctor doesn't have as much buy-in as someone else. If your doctor happens to be your clinic champion for this, then that's fine. But most of the time, when you're talking about delegating work and shifting tasks to someone else, and they're the ones accepting more work, they need to be the ones that pick the visual measure. And so, anyway, this, I think this is really powerful. It's really simple. It doesn't take a lot of data requirements. It's not something that is going to require a lot of programming. But if you've got it in your break room and you have to look at it every time you eat lunch, you're going to start printing out your after-visit summaries. Huddles. So somebody talked a little bit about huddles. These are short, and there's a, again, I put in the family practice management. If you search on YouTube, you can actually find some really good videos of huddles that you can show in your meetings when you're teaching people how to huddle. So the idea is it's a daily meeting of your team lit, which is whoever you happen to be working with that day, which is usually just the doctor and the MA most of the time. But you meet prior to each session. There's some rules about this to actually standardize it and make it doable. In the beginning, it's pretty tedious, just like all the rest of the stuff. It takes time to figure out how to do it. Towards the end, it becomes very efficient. It makes my clinic run so smoothly because they know exactly what my restrictions are today. They know what I'm working on. They know what they're supposed to do. They know where they can find me. They know if I'm going to leave early and go to a meeting. They know if I don't have my pager on, sort of all of that stuff. The logistics of running my clinic today. If you don't have meetings, you're not a team. And so this is what your daily meeting looks like. And so there's quite a bit of writing and literature about what this looks like. So these are some of the things you can talk about. Just go through this. We're out of time.
I think Ron's talk in his team.
Did he talk about it?
Talks about, well, just think about any kind of whatever sports team, you don't just go out and play. Right. Not expect to do well. You actually have a plan and you talk and you compare and all that. And then you go out and do what you all talk about you were going to do. Yeah.
And it just can make such a big difference in terms of getting PHQs or getting things done beforehand so it's ready or have it set up. It just makes it so much better.
And a lot of people just naturally do this. A lot of people run their schedule every day and tell people what they want. The difference is, this is the team talking about the schedule and the team talking about what needs to happen instead of the doctor dictating to the staff, this is what we're going to do today. And a lot of these meetings, there's really good evidence that both in your pod meetings, we call them pods, our meetings are our teams are pods, but in your team meetings, both the big meetings and the daily meetings or the teamlet meetings, another really good tip is to not have that run by the physician. So that meeting needs to be run by somebody that may not feel they have a lot of authority, because that way they learn to speak up, they learn how the process works, they learn to express their opinion, because those are things we haven't previously put a lot of value on, and it can really reverse that. When I walk into a clinic for a site visit, and I've got the MAs telling me how it is, I know they have figured it out. I've got, and I'm not talking about they're being rude or they're talking over people, but they have owned it. They know the process. They can tell me what's happening, and I know, okay, they've got the right culture set up. Yeah.
In our huddles, we have the front desk lead the huddle.
Yeah.
So we have an iPod at the front desk, and 5 minutes before the shift starts, the front desk is ready to go, and they are in the back in the pod with the provider and the MA, and it really, really works out nicely because the provider doesn't want to show up 10 minutes late when he's had 2 staff members standing there waiting for him.
Yes. And what's the agenda? You just look through the schedule and
there's an agenda. So there is actually a framework. If you go to the article, it tells you exactly what you should talk about. And it changes because all of those things are not applicable every day. But the agenda is typically sort of looking at your schedule and saying, okay, I have 4 14-year-olds coming in today, which would be an amazing day, I want all of them to have this vaccination. Or it's flu season, just ask everybody if they want their flu shot and vaccinate them and write the order. It's sort of that, what's the theme of the day sort of scenario. Yeah.
I just have a question to those of you that are doing your huddles. Currently, our nursing schedule starts about a half hour sooner than our provider schedule so that they can begin doing fasting labs and so forth. How do you address that, or do you have a model like that?
So, I mean, I can answer you. So I think they could start a half an hour early on just the regular protocol stuff, because you're already going to have some of it written down, and so there's a lot of stuff that they can be doing, and so at the point that your provider gets there, the huddle may start with, I've already done fasting labs for X, Y, and Z people that are on your schedule. It doesn't have to be that the work can't start until then. It just means that you at that point can catch up whoever's coming onto the team and say, this is what's already been done, this is what we need to do. Yeah.
I'll tell you, we, in order to get OSHA points of some sort, I don't understand that whole world, but our safety officer required a stretch and flex period. And there's a routine of exercises that you go through to be part of the stretch and flex program, and it was to decrease work injuries. And what we found, that was the perfect time to huddle, because a different MA every week ran the stretch and flex. And so they would bring those issues, and it's about a 10-minute or 12-minute a period of time where all of the MAs get together. Unfortunately, we haven't had the physicians involved or the other providers, because usually they're rounding at the hospital or have other duties, but at least from the standpoint of the flow, front office to back office, looking at the open schedules, figuring out where there's time, what patients absolutely can't be double booked, and it has made a pretty significant difference. And then we combined it with another thing, so that to kill two birds with one stone. It's been positively received, partly because even if people don't want to speak up, they're getting something out of the meeting, if nothing else, improving their flexibility. And
your huddle should be about 3 minutes on average, and it's actually been shown that if you do it with all members standing, if possible, it really prevents it from droning on and on and on and on. We're all sitting down and it's forever. So we're running into our next session. Again, I'm thrilled that everyone was engaged. This is my economic impact slide that I promised you. Cost per visit hasn't decreased so far in any of the studies shown. Okay, that's what you all want to know. But satisfaction and turnover have improved tremendously, and I do believe there's economic value that we can put on those things. We may not have the models to tell us what that is right now, but if your turnover rate, I mean, I've seen estimates of turnover that it costs 30% of the yearly wage of the employee, and if you drop your turnover rate by half, that is real value. Patient satisfaction, if they are referring people to you, I mean, if you're trying to increase the number of patients in your panel and your patients are satisfied, this is a marketing tool too, and that has real money and real value. And so I drank the Kool-Aid, I admit, but I feel like I see where, I mean, I look at my own billing as a resident, was very competitive, and I billed quite a bit more than my resident peers. I saw a lot of patients, and I was definitely the resident champion for this and did more of this other stuff. And so my N1 experience is that I've definitely generated more income, but it's kind of hard to say. So, and this acknowledges these other issues. Teamlet, I promised you teamlet, and we didn't get there, so I want to just point this out, that there's this whole idea about the teamlet, which is really cool. It really changes the idea of the 15-minute office visit being where most of the stuff happens, but that the time with the doctor is actually the smallest section of a whole process that includes pre-visit, office visit, and post-visit management. This works really, really well for providers that are in practices with smaller numbers of people and smaller teams, and can't sort of buy into the whole like 6 staff people per provider type message. So same guy, Bodenheimer, so it's still kind of, like you said, it's good stuff. And then some more references in my slides for you to take.
Can you go back?
Yes. Thank you all. And you know,